Now we'll talk about the cardiovascular system. Because heart disease affects people of all ages and can cause serious complications, your ability to examine the cardiovascular system and teach self-care is a vital skill. To help sharpen your ability, this program will show you how to inspect, palpate, percuss, and auscultate the heart and assess the neck vessels. Throughout this examination, you'll see normal findings. Keep in mind that you may see these findings in your practice, or you may see normal variations or abnormal findings.
Before examining the heart and neck vessels, consider their anatomy. For example, visualize the major neck vessels, the carotid artery, internal jugular vein, and external jugular vein. The carotid artery lies in the groove between the trachea and sternomastoid muscle. The internal jugular vein lies deep and medial to the sternomastoid muscle. Although the vessel may not be visible, its diffuse pulsations may be seen in the sternal notch in a supine person. The external jugular vein is more superficial. It lies lateral to the sternomastoid muscle, above the clavicle. Beneath the precordium on the anterior chest, envision the heart and great vessels. The heart is like an upside-down triangle. Its top is the broad base, and its bottom is the apex, which points down and to the left. During contraction, the apex produces an apical impulse, which normally is palpable at the fifth interspace, 7 to 9 centimeters from the mid-sternal line. The heart's chambers include the right atrium, right ventricle, left atrium, and left ventricle. The atrioventricular, or AV valves, separate the atria and ventricles. On the right is the tricuspid valve. On the left is the mitral valve. Two semilunar valves are set between the ventricles and the arteries. On the right is the pulmonic valve. On the left is the aortic valve. The right ventricle forms most of the anterior cardiac surface. The left ventricle lies behind it and forms the apex and part of the left border. The right atrium lies to the right and above the right ventricle, forming the right border. The left atrium is located posteriorly. The great vessels of the heart include the superior vena cava and inferior vena cava, which return unoxygenated venous blood to the right atrium. The pulmonary arteries, which leave the right ventricle and carry unoxygenated blood to the lungs. The pulmonary veins, which return freshly oxygenated blood to the left atrium. And the aorta, which carries it out to the body.
Mr. Zamora, how
Hi.
are you today?
Fine, thanks.
I'm going to feel your neck and feel your carotid arteries.
To assess the carotid arteries, palpate them one at a time. Using your index and middle fingers, gently palpate the artery medial to the sternomastoid muscle in the lower half of the neck. Feel the contour and amplitude of the pulse, which should be the same on both sides. Normally, the contour is smooth, with a rapid upstroke and slower downstroke, and the amplitude is moderate.
Mr. Zamora, I'm going to use my stethoscope now and listen to your carotid artery.
Next, auscultate the carotid artery. With the person's neck in a neutral position, ask him to take a breath, exhale, and hold
I'd
it.
like you to take a deep breath.
As he does,
Exhale.
lightly
and
apply
hold
the
it for me,
stethoscope
please.
bell over the carotid artery at the angle of the jaw, mid-cervical area, and base of the neck. You should hear no bruits, which are blowing, swishing sounds that suggest turbulent blood flow and atherosclerotic narrowing of the carotid artery. Bruits sound like this. For an older person, palpate and auscultate the carotid artery with caution. Avoid pressure on the carotid sinus area, which could slow the heart rate and compromise the circulation.
Take a breath. Mr. Zamora, I'm going to ask you to lie back.
To
please,
examine
so I
the
can examine
jugular
muscles in your
veins,
neck.
begin with the jugular venous pulse. To do this, help the person into a supine position at a 30-degree angle. Turn his head slightly away from
I'd
you
like you to turn your head
and
to the
direct a
left for me,
strong
please.
light tangentially across his neck to highlight pulsations and shadows. Look for the external jugular vein, which is usually visible over the sternomastoid muscle. Because the internal jugular vein is more reliable for assessment, but harder to see, look for its pulsations in the sternal notch, or the area where the sternomastoid muscle meets the clavicle. Don't confuse jugular venous pulsations with those of the carotid artery. Jugular pulsations normally have 5 components, with 2 major upstrokes per cycle. They are more undulant and diffuse than carotid pulsations, which have 1 smooth rapid upstroke and a more gradual downstroke with a dicrotic notch.
Mr. Zamora, I'm going to use rulers now. and measure
Next,
the pressure.
estimate the jugular venous pressure.
You'll feel me touching
To do
your
this,
chest.
hold a ruler vertical on the sternal angle. Align a straight edge perpendicular to the ruler and adjust its height to the level of pulsation. Read the level where they intersect, which should be 2 centimeters or less.
Mr. Zamora, I'm going to put your head
If
down
you
now.
suspect increased venous pressure, assess for hepatojugular reflux, which is an advanced technique. With the person supine and breathing quietly,
I'd like you to breathe with your mouth
press
open
your
slightly
right hand
while I
firmly
put your
into the
belly.
right upper quadrant of his abdomen and hold it for 30 seconds. As you do, watch the level of the jugular pulsation. It should rise briefly and then fall to the previous level.
I'm going to take a look at your chest now.
Using tangential lighting to accentuate movements, inspect the precordium and observe for the apical impulse. When visible, it occupies the 4th or 5th interspace, at or inside the midclavicular line. Note any abnormal visible pulsations, such as heaves or lifts, which are sustained thrusts of a hypertrophied ventricle. Heart disease is more prevalent and deadly among blacks than among other racial groups. So be especially alert for abnormal findings and a history of cardiac disease and risk factors in these individuals.
Can you take a deep breath, exhale, and hold it for me, please?
Palpate the precordium, localizing the apical impulse with 1 finger pad. If you have difficulty, ask the person to exhale and hold it.
I'd like you to roll on your left side.
If you still can't feel the impulse, roll him midway to his left to displace the impulse slightly to the left, and palpate again. After finding the impulse, note its location, which should occupy the 4th or 5th interspace at or medial to the midclavicular line. Size, which normally is 1 centimeter by 2 centimeters. Amplitude, which should be a gentle tap, and duration, which should be short.
Roll on your back, please.
Using the base of your fingers, palpate the apex, left sternal border, and base to detect any other pulsations. Normally, none occur. Note any abnormal pulsations such as thrills, which are vibrations that feel like a purring cat's throat and accompany loud murmurs.
I'm going to be listening to your heart in several places. Just because I'm listening a long time, it doesn't necessarily mean that something's wrong.
Before auscultating heart sounds, identify the areas where you will listen. Plan to listen in the areas where the sounds of the valves are heard best. These include the 2nd right interspace, which is the aortic valve area, 2nd left interspace, which is the pulmonic valve area, 3rd left interspace, which is Erb's point, left lower sternal border, which is the tricuspid valve area, and 5th interspace at the left midclavicular line, which is the mitral valve area. Also auscultate in other locations. Move the stethoscope slowly in a rough Z pattern from the apex of the heart, across and up, and then across the base. To evaluate heart sounds most accurately, focus on just one sound at a time and follow these steps. At each location, note the heart rate and rhythm. Identify S1 and S2. Assess S1 and S2 separately, and listen for extra heart sounds and murmurs. With the diaphragm, first note the rate and rhythm of the heartbeat. Normally, the rate ranges from 60 to 100 beats per minute, and the rhythm is regular. In children and young adults, sinus arrhythmia normally may occur. This variable rhythm increases with inspiration and decreases with expiration. Next, identify S1 and S2. Because S1 is the start of systole, it is the reference point for timing all other cardiac sounds. Usually, S1 is easy to identify because you hear two sounds close together, lubbed up, and S1 is the first one. To help identify S1 and S2 accurately, also remember that S1 is louder than S2 at the apex. S2 is louder than S1 at the base. S1 coincides with the carotid artery pulse, which you can feel when you hear S1, and S1 coincides with the R wave on an ECG monitor. Now concentrate on S1 and S2 separately, noting whether each sound is normal, accentuated, diminished, or split. Inch the diaphragm across the chest as you do this. S1 is caused by closure of the AV valves. It is loudest at the apex and sounds like this. At the base, S1 sounds like this. S2 is caused by closure of the semilunar valves. It's loudest at the base, where it normally sounds like this. At the apex, it sounds like this. In the pulmonic area, you normally may hear a split S2 toward the end of inspiration, because deep inhalation prevents the aortic and pulmonic valves from closing at the same time. A split S2 sounds like this. Next, listen for extra heart sounds and murmurs during systole and diastole, which usually are silent periods. If you detect these sounds, note their timing and characteristics. You may hear a mid-systolic click early in systole. This short, high-pitched abnormal sound results from mitral valve prolapse and is best heard with the diaphragm at the apex. Switch to the bell to detect a third heart sound, or S3, which may occur early in diastole. Caused by ventricular filling, S3 is a dull, soft sound like distant thunder. In an adult, it may signal heart failure. Now listen for S3, which sounds like a galloping horse. A fourth heart sound, or S4, may occur late in diastole, just before S1. This ventricular filling sound is very soft and low-pitched. Now listen for S4. Also listen for murmurs, which are blowing, swishing sounds that result from turbulent blood flow in the heart or great vessels. A mid-systolic murmur sounds like this. If you detect a murmur, note its characteristics, which include timing, such as during systole or diastole, loudness, from grade 1, for barely audible, to grade 6, for audible even with the stethoscope lifted slightly off the chest, pitch, which may be high, medium, or low, pattern, such as crescendo, growing louder during the cardiac phase, or decrescendo. Quality, which may be musical, blowing, harsh, or rumbling. Location of the area of maximum murmur intensity. Radiation, which includes areas where the murmur also is audible, and the person's posture when the murmur is heard. In adults, you normally hear no murmurs. In healthy children and adolescents, innocent murmurs commonly occur because their hearts have a greater contractile force, which increases blood flow velocity. An innocent murmur usually is grade 2, mid-systolic, and short, with a crescendo-decrescendo pattern, and a vibratory or musical quality.
Mr. Zamora, I'd like you to roll on your left side, please.
After auscultating with the person supine, roll him toward his left side. Listen with the bell at the apex to detect any S3 or S4 heart sounds. You should hear none.
Now, I'll have you roll back on your back. And sit up.
Then ask the person to sit up,
Let me help you.
lean forward slightly, and exhale. Press the diaphragm firmly at the base, right side, and left side to listen for murmurs. You should hear none. In older adults, you may hear an occasional systolic murmur or an S4 or premature ectopic beat. Although these findings may not signal heart disease, obtain an ECG and a referral.
Mr. Zamora, your exam was
When your
formal.
examination of the heart and
Is
neck
slightly
vessels is
elevated.
completed,
Do you have any questions?
discuss your findings with the person and answer any questions he may have.
Family history of heart disease.
Based on your findings, teach him about health promotion and self-care topics to improve and maintain his cardiovascular health.
Exercise, avoiding smoking,